Yes. Thanks, Becky. And thanks, David, for the introductions. Julie, I'll go ahead and start the presentation that has both of our information in it and just move slides for us.
All right, thank you. Thanks so much.
Absolutely.
I don't see the presentation, but I have it up. Can I, maybe there's a different view. I'm sorry, guys. Speaker? Nope, I see you, Tricia. Let's see. Can everybody, yeah, there you go, Tricia. We got it now.
Yep.
There it is.
Just took a minute to show.
Fantastic. So I really very much appreciate this opportunity to talk with you about breast and cervical cancer as we're talking about the breast and cervical cancer program, as we are talking about getting a plan for your patients and clients to really have bought into. So Brent's going to sort of give you some of the juicy stuff, but I really wanted to take this opportunity to try to get some of our critical access hospitals participating in the breast and cervical cancer program. We do have hospitals across the state, and Becky, do you have your hand up? Okay, I'm going to keep going, I think. And it's a great program.
I don't have my hand up.
Okay.
Yeah.
It's a great program that really can remove barriers. One of the things that Brent is going to talk about is getting buy-in for their participating in their healthcare, and lots of ways of doing brief action planning, and Tricia's program utilizes that as well. But one of the things that a lot of our folks will say is they don't have access, it's difficult, they can't afford it, et cetera, et cetera. And so this is a way to really, once they're ready to move, to remove any of the structural barriers that are part of them. And so we want to encourage folks to participate. All right, let's go to the next slide. I think this is our mission. Should I try to advance it, Tricia?
If you shared the presentation, Julie, you'll need to be the one that advances the slides.
I did not share. Okay.
So whomever loaded them will need to advance the slides.
There we go. I think you've seen this already today because we've had several of our presenters, but again, this is the mission and the vision for the Indiana State Department, or the Indiana Department of Health. We're all having to learn to take the state out, and very important to everything that we do. Next slide, Tricia. So the Indiana Breast and Cervical Cancer Program, I just want to give you history because sometimes this is not a newfangled program. This was started in 1990. Congress passed the Breast and Cervical Cancer Mortality Prevention Act, and this was a screening program. It took another year or two to make sure that we had then an easy avenue for folks to then be enrolled in Medicaid if there is a diagnosis found. Indiana was in the second cohort that went, and so far this is our only national screening program. We continue to work towards getting colorectal and lung cancer screening in the state with some federal funding, but this is the only one that is in all 50 states. Our next slide, Tricia. Again, it is this comprehensive public health program. It takes women not only through the screening for breast or cervical cancer program at or below 200% of the poverty level if they cannot afford it, but it also then we can enroll them swiftly into Medicaid if a diagnosis is made. And that's really important. A lot of our women will say, I don't want to know because there's nothing I can do about it, but there is something they can do about it. And again, it is a cooperative agreement. This is our year to renew our cooperative agreement with CDC. It is considered a competitive agreement, but we are very hopeful to continue. And we have had this program for about 29 years here in Indiana. So we're very hopeful to continue. If you want to go ahead and slide to the next one, Tricia. Kids in all 50 states and 13 tribes, and in IN-BCCP, you'll hear us call that, and it stands for Indiana Breast and Cervical Cancer Program, is Indiana's version of this program. Okay. How about we go to the next one? Just so you know, this was, I think, 2 years ago, 2019. Yep, 2 years ago. The women that we served in that 5-year period was 12,694 unique women. And so you will see a crossover because some of our women receive both cervical cancer and breast cancer screening, and some just receive one or the other. But in those 5 years, 12,000 women, of course, we have a lot of repeat customers, which is exactly what we want. And especially when Tricia starts to talk about what she can offer in WISEWOMAN, we do want them to keep coming back so that we can keep offering other kinds of care for them as well, and supports to help them improve their lifestyle. Next slide. This is in our 29 years. We've had 145,000 unique visits and over 68,000 women. And so we really are very, very proud of it. We do occasionally get to the end of the year on a hope and a prayer that we have enough dollars to go through. But we have successfully asked CDC to give us some additional dollars for more screening, and they have done so. So we really want to provide access. And you'll see when we get to our map of Indiana, which I think is a couple slides from now, we do have some places in the state that we really need to get some additional providers. All right, next slide. So the way this is organized is we have 3 regions in the states, cleverly named North, Central, and Southern regions, and they each have a regional coordinator. And those regional coordinators reach out to providers. And again, we do not establish what that provider has to be, just that they provide breast and/or cervical cancer screening. And then we look for different kinds of services so that woman can be successfully navigated to where she needs to go. Go ahead, next slide. We have at the state level 2 nurse consultants. Some of you may know Judy Capone or Carol Combs. They seem to be the ones that are most known because they're out doing a lot of the work. A data manager, do be aware that we do have to collect data on this program since this is CDC funded, and it does go all the way up to Congress. And then we have a principal investigator. And then again, those 3 regional coordinators, one at United Health Services in the Northern region, her name is Lauren Dietz. The Central region is the YWCA Greater Lafayette, and that would be Amber Thurman at this time. And the Southern region is Family Health Centers of Southern Indiana. And that person right now is Alicia Swank. All right, and the next slide. So who is eligible? These are the women that can come in. They have to be an Indiana resident. They can be insured, just underinsured. And we sometimes especially enroll women at diagnostic levels where they are insured for a regular screening mammogram. But then if something's concerning, we can bring them in for an ultrasound or different diagnostic as well. So sometimes that's where we see them. We enroll them at the diagnostic level. And some of those women, in fact, I wouldn't say a high percentage, but that's where we see a lot of our women who are what we would consider underinsured. Insured with unmet deductible, ages 30 to 49 are generally available, or generally can access any of our cervical cancer screening. And then ages 50 to 64 years of age are eligible for an office visit, clinical breast exam, pap smear, and mammogram. Do know that we do have an ability, and again, sometimes people are say why 50, not 40. We're following right now the United States Preventative Task Force recommendations, but we can enroll women at a diagnostic level. So our regional coordinators are really masterful about finding if a woman is concerned, but let's say she's 45, really masterful about getting her enrolled using other dollars to do the initial screen, and then coming back through if she needs a diagnostic one. And again, at 65, we encourage them to go to Medicare. Do know that we reimburse providers at Medicaid rates. So again, we're looking for providers who are willing to work with us and get these women screened. All right, next slide. This is where we're asking there's a slide coming up, like I said, it's going to show some of the regions that we have, or some of the counties that we have. We just don't have a provider, and it can be challenging for a woman to get there, get childcare, get transportation, and it just is, again, one more place where they can say, we'll wait. We do enroll at a wide variety of clinical settings, and we have a mix of providers across the spectrum of well woman care to assure that a woman's breast and cervical cancer screening needs are met. To become a provider, we need to have this updated provider agreement on file with updated billing and banking information. We do have an IN-BCCP provider manual, and a lot of folks can look at that and decide whether or not they can adhere to that. One of our larger problems is how quickly we need to have our claims submitted. We have about a 60-day framework because we need to keep following that woman. So that can be a difficulty. On the other hand, it does help us get you paid more quickly, and then claims are paid at Medicare rates. There's a link here, and I'm happy to talk to anyone about reviewing the provider manual, talking about this program, getting enrolled. So again, seeking providers. And again, we have folks who are doing just PAP or just breast exams or just diagnostic, or we have folks who can do them all. And we will work with any of them. We know what our providers can provide, and we help to meet women where they are and move them through the process. Next screen. These are our information. Judy Capone is the MA12 coordinator. We are going to talk just a little bit about MA12 in the next set of slides. And she is, and MA12 is if there is a diagnosis made, how that woman is enrolled. And Carol is our nurse consultant right now. Both are wonderful resources. Next slide. These are the regional contacts, and we talked about sometimes the person changes, but these are who they are at this point. Also a great place to start. I would refer your women there first, because again, they sometimes are braiding additional funds that they get from other sources, such as the license plate funds, the IPCAP funds. All right, next slide. This is my I don't know. I hope not my Achilles heel. You can see that there are spots in this state, and they are grouped together. Well, we don't have providers. If you look at them, and some of you are in some of these counties, and we would really love to talk to you about at least getting some of these services, even if a woman might need to go somewhere else for these other services. Particularly in our southern region, there's a large number of counties that do not have a provider on our list. That means those women need to travel quite a bit further than other places. We do have a lovely presence. I know Gibson County, you probably Deaconess and Vanderbilt County serves their breast center, serves a lot of our women. So you may be referring to them as well. Because you're right there, we just heard your name, but we are looking for as many providers as we can. And we are aiming to have a woman be within 40 miles of getting these services. And at this point, we're probably close, except for that region in the southern Indiana. And we would also not have any problem if a woman was just 5 minutes away from it as well. So again, looking to enroll and recruit new providers. And again, the dark purple is where we have some. It does rapidly change. We just enrolled somebody today. So we do get new providers falling on and off every day. Tricia, next slide. I think we're into the MA12. And if anyone is interested, we are, Brent can talk about this too. We do work with linking our patients across the spectrum, again, from the community to screening. Tricia's going to talk a little bit about how WISEWOMAN does that, and as well from the screening out into the community. We do quality improvement, and I'd be happy to talk to anyone who would like to engage in how you might drive up your breast and cervical cancer screening rates among your eligible population. And then we are doing some work with employers to try to allow, again, remove some of those structural barriers like insurance or time off work. All right, next slide. The MA12 program has a very similar eligibility. And again, what happens is they've been diagnosed with breast or cervical cancer, and we can enroll them immediately into Medicaid. They can come in two ways. They can come in from our program, BCCP, or they can come in from the outside. MA12 is when they come directly from BCCP. We have a lot of their paperwork already on file. We can speed it up even more. Having spoken to a lot of really upset women, it is great to have an answer when they are truly frightened. And if they're coming from outside of BCCP but still need to be enrolled and are under 200% of the federal poverty level, which is a lot more generous than the 138, 139% for Medicaid, again, we can enroll them for the duration of their treatment. Okay, next slide, please. We talked about this, the higher income threshold. There are no premiums for this, and it is traditional Medicaid, and it includes a wide variety of breast and cervical cancer services, but also vision and dental. So again, if you have a woman who is diagnosed, even if she did not come through our breast and cervical cancer program, but she is 200% or below of poverty level, we can enroll her. All right, next slide. The way that we do it is the patient or the provider contacts, and in this case, it would be Judy, who is our MA12 Option 3 coordinator. The coordinator speaks with the patient. We send an application. Again, in this case, we have a nurse who is walking through the process with them so that nothing gets lost, especially when our women are in crisis. They need as much hand-holding as they possibly can. A lot of times, our nurse consultant works with the patient navigators, if you have that on staff. If not, there's additional supports to help that patient get enrolled. And then we turn that over to FSSA. So the staff is embedded here, but we do work with Medicaid to make sure that that personal identification number is issued and that woman is enrolled for the duration of her treatment. So Becky made sure to say call to action. This is a good program. We probably all agree on that, but what we really want to do is see an increase in the number of providers, especially in our rural and uncovered counties. You saw those. If you're in a county that has coverage, we would be happy to take you on as well, but especially in some of our rural counties, we are really interested in getting some additional providers, and we'd be happy to talk to you. We don't want our women to have to travel again more than 40 miles, and we would be happy if it was closer and easier. Consider ways to improve clinical practice through the use of evidence-based interventions. And I'm happy to do a 101 on that. Brent and I are happy to do some coaching on that. And again, if you want to think about how your clinic improves around just getting those women up to date on their screenings, and then reducing any structural barriers is what I consider BCCP. It's really its big strength. We can take away the concern about being diagnosed and then what, and we can take away the concern of, I can't afford it. Finally, and this is where we turn it over to Tricia for Weizmann, which is some of the things that we do. But again, there are risk reduction strategies that a woman can take to reduce her risk of breast and cervical cancer. And our physicians and nurse practitioners and nurses are aware of many of them. And we encourage you to continue to stress behavioral health for your women around healthy lifestyle behaviors. I'm going to turn it to Tricia now. And I think at the end, if there's time, we're happy to come back. Again, we would love to talk to you if you would consider it.
Julie, there was a quick question.
Sure.
Please confirm on the county map slide, are the colored counties those that do not have a provider enrolled?
No, the colored counties are the ones that do have a provider. Okay. They do have a provider for BCCP. Now, our BCCP providers, we have some that do one woman every 2 or 3 years, right? So they know it's there, but they may not have a woman come in all the time. Or we have heavy hitters that we enroll. They enroll literally hundreds of women every year. But the pink counties or the purple counties, depending on what you see in that color, is they do have a provider there, at least one. And they might have multiple, but at least one.
Thank you.
Thank you.
All right. Hi, everyone. I'm Tricia. I'm our WISEWOMAN program director. I believe David may have mentioned the acronym for WISEWOMAN stands for Well Integrated Screening and Evaluation for Women Across the Nation. And it's appropriate because it's CDC funded, and the way that they kind of built this program is to integrate it into the breast and cervical cancer program. So that's why Julie and I are typically working together on this. The participants that are in the BCCP program are the only ones that are eligible for the Weizmann program. So trying to collaborate together to ensure that these participants kind of get this full circle services. All right, I will try not to speak in acronyms today, but these are a lot of the acronyms that are associated with WISEWOMAN. So you'll see those throughout. But just a quick overview of the Weizmann program. Again, it is CDC funded. It started back in 1995 with some research projects, but in 2008 is whenever it actually became that extension to, it's called the National Breast and Cervical Cancer Early Detection Program, but we just call it the Indiana BCCP program for short here. And the overall goal is to basically get the same participants who are coming in for those breast and cervical cancer services to then go full circle and get them their cardiovascular disease, diabetes screenings, and work on prevention of those diseases as well as lifestyle behavior changes. And then it kind of becomes a full gamut for that one participant. She's not only coming in for that one office visit and then see ya, next year. She's coming in and she's getting all of the above to check all of the boxes. So Indiana was first awarded back in July of 2013 for a 5-year grant. And we are actually in the 4th year out of our second 5-year grant cycle. So we are fully funded through 2023. Okay, so our regions for the Weizmann program are, of course, the same as BCCP, because again, we're kind of working with a lot of the same providers and a lot of the same participants. So our northern region here is in green, central in blue, and we're really excited because just a couple of months ago, we just started in our southern region. So we're getting set up with our coordinating office at LifeSpring Health Systems down in Clark County. So very excited to have started in the Southern County, but as you will see, we also are lacking for just where our services are actually located. So the blue counties on the map are where we actually have Weizmann providers. We're lucky that via some of the transportation services that we offer and different things, we're able to actually serve women in the green counties as well, but our providers are only located in those blue counties. So this whole southern and southwest kind of portion of the state is where we're really looking to grow. Eligibility is very similar to the breast and cervical cancer program. Again, the participant does need to be in the BCCP program first before they can get enrolled into Weizmann. They must be an Indiana resident. We work with the underinsured or uninsured population at or below 200% of the poverty level. The only big difference is the age range. So we serve women between the ages of 40 and 64. Weizmann has 3 main strategies. We track and monitor clinical measures, which is shown to improve healthcare quality and identify patients with hypertension. We also are working with our providers to ensure that they're utilizing team-based care. This is also shown to reduce cardiovascular disease risk. And the CDC has the Weizmann program focusing on hypertension control and management. And then finally, we link community resources and clinical services. So one of the biggest things I know Julie alluded to, so we support bidirectional referrals, self-management, and lifestyle change for these women who may be at higher risk for cardiovascular disease. Okay, so our screening services include an initial cardiovascular disease risk screening. So it's kind of your typical well-woman type visit. You have your height, weight, BMI, waist circumference, blood pressure, all cholesterol, and then glucose or A1C. And we will do a follow-up screening with these women after they go through some of their, what we call healthy behavior support services. So that's my favorite part about our program, is that you're not, again, just coming in for your one office visit, learning that you may be at higher risk, learning that your lab values are higher than we would like to see, and then being told do something about it, and then you don't see them for another year. With the WISEWOMAN program, you do get to come in, you find out what your numbers are, we go through some risk reduction counseling with you, and then we will get you enrolled into what we call those healthy behavior support services. So that includes things like health coaching, diabetes prevention program, Purdue Extension's Eat Smart, Move More. So you'll go through those programs and then actually come back and see us again for a follow-up screening. So just to see kind of where you are, it's typically between 3 to 6 months that those programs run. So just to see if you've made improvements during that time. And then where can we get you to go before we have you come back in for the rescreen 12 to 18 months after that initial screening. We will also help pay for, we have medical or medication follow-ups depending on what the patient needs whenever you find out their lab values at their screening. And so we can pay for some additional labs as necessary. So again, our healthy behavior support services, they all need to be CDC approved and evidence-based, but we actually did just get the Heart Healthy Ambassador Self-Monitored Blood Pressure Program approved, as well as Noom, if you are familiar with the app. So we're very excited just to be expanding some of the choices that we have for the women based on their needs, their interests, and then kind of their goals and what they're able to access. We also offer program supports. So it's not just going to some classes or having phone calls for health coaching sessions. We actually do offer some additional supports just to really promote those physical activity and nutrition type changes and needs. So we will give a gym membership for up to 6 months, but we have a stipulation that you need to attend that gym at least 8 times per month to keep your membership going. And then, especially during COVID, we worked with some flexibilities to offer at-home workout equipment as well. So we were giving some bands, mats, things like that to women who, sometimes gyms were closed during COVID. And even still now, we don't have some of the gyms that we used to have last year. So just to keep them being active in many different ways. And we're teaching them how to kind of use this equipment through some social supports and during their health coaching sessions and such. So optimally, this is what the program would look like. And this is where we kind of intertwine BCCP and WISEWOMAN. So the patient is going to be scheduled for their BCCP office visit in the many different ways that Julia talked about. And then if they're eligible for WISEWOMAN, just making sure that they meet that age range eligibility. Both services would happen during the same office visit. So they're not going to come in for a couple of services and then get scheduled for a different day, which again leads to all the barriers of just coming in for that amount of time and the transportation and that type of thing. So optimally, everything would happen during the same office visit. So you're going to conduct that cardiovascular screening, cardiovascular risk screening, health assessment, and risk reduction counseling. If a medical follow-up is necessary, you will either provide that then and there, or you will refer them to where they need to get that follow-up. The woman will be referred to and enrolled in a healthy behavior support service. And 4 to 6 weeks after she completes that HBSS, she'll come back in for that follow-up screening. And 12 to 18 months after the initial screening, she would get her rescreen. So 3 different screenings per annual cycle to really keep these people engaged and really think about changing their lifestyles. So these are some of the partners that we have in the program. You'll see that we have things under tobacco cessation, physical activity, nutrition, mental health. We're always trying to make sure that different things that may be brought up during health coaching sessions, we have somewhere or some entity to send these participants to. And these are things that we'll talk about in our community scan here in just a second. So women that we've served, our goal each year is to serve at least 500 women. In year 3, which most of that year was basically in the pandemic, we start our year on September 30th, roll through September 29th. So this last year, we had almost 300 screenings. and 400 health coaching sessions were facilitated. So we had 49 women actually complete their health coaching, which we were really excited about, to continue something like this whenever, you know, physical activity or moving more or eating healthier may be the least of your worries. We're just really excited that we kept these women engaged and kind of going through the program. So some unique barriers in the Weizmann population. We just did a participant survey with some of our patients. So we were excited to just kind of get their feedback. The top 4, time and cost, are not surprising. Transportation is not really surprising either, but something that's unique is not all of the women who we serve have citizenship. And so, you know, you can't get a license at that point. They're kind of depending on friends and family to be getting them to their appointments. And so it's been a really big barrier for both of our programs. So just something that we're always trying to work on. And then 4 is that they don't really have the motivation to be healthy. And this is the biggest thing that we're really excited about, that health coaching we kind of have based in what you may have heard from Brent, and he's going to be speaking on a little bit later. All the motivational interviewing and brief action planning objectives. So just to bring those into our health coaches, making sure that they're trained in that and that they're able to have those conversations with the participants is really important to us. So we're hoping that number 4 kind of changes in our next annual participant survey. But it's just really, really good to know what they're kind of up against. All right, so my call to action for you guys is always prevention. That's been my number 1 focus. It's always at the top of my mind. So I mentioned the community scan earlier. So just making sure that you have a community scan created and you keep within your organization is always important. It helps us, again, to just identify, like if you're going to have a patient in front of you and use motivational interviewing to better understand what's going on in their life. Do you have different resources that you can refer that person to that may be necessary, but not in your wheelhouse? So having that community scan to know what's available in your community and that you and your staff know to send that person to. If they bring up A, you send them to B, like that kind of thing. It's been really helpful for our providers. And then in conjunction with the community scan, we also have bidirectional referral maps. So pieces of the community scan we put into a bidirectional referral map to kind of show the staff at our providers of who are you, and to work with the providers for us to better understand who are you sending participants to, and then which of these organizations are you getting feedback from, so that we can get that full picture of what programs are our participants taking part in and what's leading to the best outcomes. So those 2 things have been important for us. And always referring to lifestyle change programs. So just encourage you guys to have, to take note of what's available lifestyle change program wise in your community, and just making sure those things are on your community scan so that you can refer, because we can't necessarily always change someone's lifestyle in the time that you have them in your office. So just making sure that you're helping get them to something else that can provide further time with them. And then, of course, referring to the Weizmann program. So you guys saw where we are currently located. And if you have any questions about how you can get more involved, or if you would like any assistance with the community scan, bidirectional referral maps, always let me know. But then on that note, with using the spirit of motivational interviewing, I will turn it over to Brent.
Thank you, Tricia and Julie. No questions in the queue for you at this time, but we may have some later. If you'd like to stop sharing, then we can have Brent share his presentation.
Thanks, Becky.
Thank you. And Brent, are you able to share?
I think that Brent is still.
It's coming in. Julie's pins.
He's coming. We're sharing our nice little back room here, so
Gotcha.
we'll
Okay.
help each other out. He's got it.
Hey, Becky, and hello, everyone, again. I am going to share my screen. And someone mentioned the virtual gremlins. Let's just hope they leave us alone, because they do want to show up from time to time.
And make sure to click the audio button when you're sharing for your videos.
Oh, that was my question. Okay, let me get back out of here. Stop share. Share screen. Share sound. There it is. We use Teams, and I hadn't done that in a while, so thank you, Becky. All right. All right, so I went to the last slide I was on. Okay, can you guys see my screen?
Yes.
Yes. And I'm so sorry because it went to the end of my presentation for some reason. All right, so Brent Anderson, formal introduction. I am a practice coach with the Indiana Department of Health. I work with health system teams doing practice transformation work. So that's everyone from CEOs to the front desk folks to everybody that's engaged in every part of the interaction when it comes to managing things. And so we're going to talk about brief action planning today. I have a question for you folks in the chat. If you have MI experience, motivation interviewing training, please let us know. If you have training and action planning, let us know. That is insightful for me as we go through this, because it'll help me understand who has that experience and who might be able to help us. Today's about engaging with you guys, and it's about making this as meaningful as possible. So I need to kind of check in to see where you guys are and then make this, as meaningful for you as we can. Would it be okay if I started with the video? I want to try a video to see if I can set the stage for things. Is that okay with everybody? Thumbs up or?
Sounds good.
Sounds good, okay. All right.
The sound is very faint, Brent.
Okay.
If you've started your video, Brent, it must be on another screen. We're still seeing the slide with the link on it.
The slide with the link on it. Okay, well, you know what we're going to do? We're going to just go back to the presentation. I was afraid that was going to happen. We're going to do this without video, without audio. Okay. And I'm so sorry about that. Let's just get over here to slide. Okay. There is a video. If you go to YouTube, it is called Never Ever Give Up. And that was the intro to it. And essentially it is about a gentleman that was a paratrooper who over the years just kind of lost things and lost control of being in control of himself, and then decided to make a change. And the video is about his transformation. It's about him never giving up. As a paratrooper, bad knees and back and all the injuries that come from that, and wanting someone to help him, and went to a number of folks that just didn't want to help. And he finally found someone to support him. So that's what we're talking about today. It's about how do we support the folks that we serve, and you support them differently is the part of the training that I want to begin with. And so brief action planning, if any of you, I don't know if anyone put in the chat that they have MI training. A lot of folks are coming back from motivation interviewing training and stating that they wanted more. They wanted more tools, resources, and support. And then in primary care and the busy settings, like in the hospitals, like how do we do this in hectic settings? And so from those, from that feedback and from those trainings, brief action planning was, it has evolved as a way to help deliver MI in busy settings like primary care and hectic office settings. And it is a highly structured, patient-centered, stepped care, evidence-informed, self-management support technique based upon the principles and practice of MI. Long-winded way of saying it's structured because there is a flow chart. So you start with the open-ended first question of, is there anything you'd like to do for your health in the next week or two? And from that, you really begin to check in with the patient to see how you can best support them. It's structured and it's guided. So as you ask the question, the flow chart guides you through the discussion with someone. And these are for folks that, that you're doing action planning with, folks you've identified, you want to put a little bit more follow-up in with them. This is not for first-time folks that you're meeting. These are folks that you have a relationship with that you're putting in a self-management support plan for them. It's patient-centered because it begins with the initial question of what is it you'd like to do for your health? What would you like to do for your health? Not what I want you to do or the health system wants you to do. You ultimately going to make the change. How do we best support you? It's stepped care. That first question tells you a lot about, is this patient motivated? Are they not motivated? Do they have an interest in making changes right now? And if they don't, stepped care is built in. It's designed to help the teams as we use the skills. It helps build in stepped care as needed in the engagement. It's evidence informed. So it's this is Landau and Associates, Landau and 5 other associates set out to see the impact that MI has and its value. And they found 48 randomized clinical controlled trials, over 9,000 patients from a variety of settings. And it was deemed that MI has a modest advantage over usual care. So there's been a great deal of interest over the last 5 or more years to really incorporate MI and how we work with folks. And what is MI? Motivation interviewing is compassion, it's acceptance, it's partnership, and it's evocation. And so by definition, compassion is caring about what's important to another person and feeling moved to help. Acceptance is respecting that people have the right to change or not to change. It's up to them. We can't make them change. It's partnership. It's working together with another person and recognize them as an equal. And evocation is bringing out another person's strengths and knowledge about the situation in themselves. And so there's just some take-home points that I want to hone in on as we talk about MI and the definition. It's a way of talking and being with someone to support them. It is a collaborative conversation. It's never a lecture or monologue. And how many times have we told people what to do and they just don't do it? They're non-compliant, right? This is about that conversation. This is about changing that and working on with the teams to have conversations that are patient-centered and respecting the fact that people have the right to change or not to change. And we're not going to tell them what to do because it doesn't work. That's what the evidence has shown us. It's about respecting autonomy. It's about people are experts in their own lives, and it's respecting that. And it's about using ask, tell, ask, and teach back, which are the best ways to use to deliver healthcare information. And so we're talking about the spirit of MI. The way to remember this is CAPE, compassion, acceptance, partnership, and evocation. And if you guys remember when you were a kid, or maybe around Halloween time, if you still do this, when you put on a cape, how do you feel? How does that make you feel? Please share in the chat any thoughts, any emotions, any ideas. What does putting on that cape do for you? How does that make you feel? And Becky, you can help me monitor. Is anyone throwing anything in the chat? I don't want to make this a monologue, so please help me. Share your thoughts on what it means when you put on a cape. How you feel?
I had somebody email me that it makes them feel powerful, like they can fly and that they can do anything.
Absolutely. And in many respects, that's our role as a provider. Was there something else, Becky?
Pardon?
Was there something else? I thought I heard you saying something.
No, the last one I saw was I can do anything.
Awesome. Yeah, yeah. And one of the recent editions of Miller and Ronick's MI work states that our role in providing support, it's really like being in the garden. It's really providing the conditions for success. It's about the sunlight. It's about the water. It's about the nurturing, the support, and being able to create the conditions for the garden to be nourished and for it to grow. And so that's what this is like. And when we put on our cape and we're talking with other folks, it's empowering. They expect us to help them. And so in many cases, as providers, we've got to make sure we have that cape on and we have that energy to create that environment of support. And then ideally, it's going to be putting that cape on the other person where they feel empowered, like they're invincible, like they can do anything. And in many cases, that's what we're trying to do. And so, the video that I was going to show you guys, and please go to YouTube and look up Never Ever Give Up. And it's an inspiring story of someone who was ready to make a change. He could not find someone to support him, but when he did, he literally from that support was able to shed over 100 pounds, and it doesn't even look like the same person from start to finish. And so that's what our role is in MI and in supporting folks. It's about using the spirit of MI in our engagements: compassion, acceptance, partnership, and evocation. Another definition is it's a dance. It should feel like a dance. It should be this beautiful thing where the other person has the lead, and we follow them through this beautiful engagement that is rewarding for both sides, for the person that's being engaged with us, and then for us, because we both are getting something out of the interaction. And if you think about the wrestling match, and I know all of you have interactions with family members, friends, coworkers, or others, where it's like a wrestling match, there is this struggle, this power struggle thing. And if you think about it, here's what the evidence in MI says: if you're in a wrestling match, and even if you win, imagine what it feels like for that person to be, on the ground, and you're going to have to help them back up and build them back up. So, even if you do win, it's still not a good feeling for that person. And then if you're trying to support them, they're beat up and they're beat down. You're going to have to build them back up. So try to keep that in mind. It's a dance. It should be a dance, and it shouldn't feel like a wrestling match. Here are the core components of brief action planning. It's the 3 things in blue and the 3 things in green that are done every time. You ask the question: is there anything you'd like to do for health the next week or 2? You ask how confident or sure do you feel about carrying out your plan on a scale from 0 to 10. And then you ask, would it be helpful to set a check on how things are going? And when you ask this question, the questions, here's how it flows. So when you ask this first open-ended question, this is MI in its introduction, as in the engagement, open-ended, you're going to find out a lot about what this person knows about taking care of themselves, what their motivation is. So you start with that question to help you as a team decide how to support them best. And so they either have an idea, they have a general idea, they may need some help, they may say not at this time. And sometimes folks have maybe been at the hospital or been in the clinic for a long time, and they're not ready for a goal setting session. It's just been a long day. So we have to respect that. So if they don't have an idea, one of the skills that we teach is offer behavior menu with permission. And it sounds like this: is it okay if I share ideas from others who are working on something similar? They say yes, share 2 to 3 varied ideas briefly or altogether in a list, and then say, maybe one of these would be of interest to you. The skill number 2 is we always do smart action planning, right? It's always what, when, where, how often, how long, how much, and a start date. And we actively practice these in the training. So the teams, when they come through the brief action planning trainings, are practicing delivering brief action planning using the questions, and then supporting using the skills. The third skill is listed a commitment statement. So the evidence says when we hear people say in their own words back what they're going to do, it's a commitment that they're going to do it. It strengthens the person's commitment to succeed. Check on confidence. You want to find out how confident are they. Here's where it helps us begin to uncover those. We talk about social determinants of health. What are their needs? What are the barriers? What's getting in the way? And the evidence says if they're a 7 or greater, they're going to be more likely to be successful with their plan. If it's less than that, that's wonderful for us, because we can begin to ask the questions of what can we do to help you get around those things that are getting in the way of you taking better care of yourself. So if it's a problem solving is used for confidence less than a 7, it looks like this. And we actually teach sticking to the script as best you can. Say the words just as they appear. So a 2 is higher than a 0, that's good. We know people are more likely to complete a plan if it's higher than 7. Any ideas about what might raise your confidence? Yes or no, and then you follow the flow chart accordingly to support them. So this is another one of the skills that we teach is problem solving. And then the last piece is checking on how the plan goes. So we put that check on progress in. And so ideally, you're going to find a core group of folks that you can follow more closely within a week or 2. And the evidence says if we support them using the spirit of MI, we can pull them back into the quote unquote normal range of things and put them back in control of taking better care of themselves. And when you do that, it just sounds something staying on the script. How did it go? They completed it, great. What would you like to do next? If they didn't do any of it, you say that happens. What would you like to do next? So a follow-up call, we actually give this out as a tool. This is what a follow-up call can look like. It can be this simple and stick to the script using the words out on the page. And the experts in MI say that the words matter. So we do encourage not going off script because it may change the tone and the spirit. These words have been selected to help you stay in the mindset of being able to support someone with MI, and language and the words are important. What happens if people don't complete any of their plan? You understand that, you know, they may be too big and you try to keep them really small. You may want to do a warm handoff and get them screened PHQ-9 or GAD-7 so that you're kind of checking in on the behavioral mental health side of things with that person and doing a warm handoff so they can get that support. You refer them to a resource, which is what I was just talking about. Use additional skills if you have them, and accept BAP is not for everyone. It's just for some folks that we've identified we want to follow more closely, and we might be able to get them into the quote unquote normal range of diabetes or hypertension or their behavioral mental health issues. We're just going to support them a little more closely because we understand they're ready to change, and we're going to support them by using action planning. So this is what it looks like. It's the 3 things in blue and the 3 things in green that you do every time. I know this can look like a lot, so our trainings are designed to spend time with your teams, helping them understand how to fully navigate through this and how to best support someone. And when you ask that first question, it's a wonderful thing because you learn a lot about, you know, the person's health IQ or just where they could use additional support, and where you guys as health system teams can help provide that support. There are brief action planning videos. I'm going to direct you to those. If you go to YouTube and look up brief action planning videos, they will pop in, and there are a wide range of them. What you're trying to do is a self-management support session that can be done in 2 to 5 minutes. And when you watch the videos, you'll see they're going to be done in 2 to 5 minutes, where you ask the 3 questions and you provide the support that's in the flow chart. That's what this is about. And this ain't for everybody. So just want to talk a couple of minutes about a few of the things that are useful to think about if you're doing brief action planning. So some of the tricks include, you know, avoid being the expert. Don't, at this point, this is when you're doing the self-management support. It's all about following that person in their dance. So you don't want to start asking a whole bunch of questions and give up the expert role. People are experts in their own lives. So you begin by asking the question and you just really listen so you know how to best support them. Step care comes from asking that first question and then being able to support them accordingly. If you're doing all the talking and brief action planning, that's probably not brief action planning. It should be about them. It shouldn't be about us talking at them. Stick to the guide. The evidence shows us these are words and these are things that have been selected to help us make it an engaging part of the process. So I know Becky uses these trainings for the patient satisfaction surveys and for other engagement. You know, how do we do engaging better than we've done in the past? And so if you stick to the script, you're going to be assured you're delivering MI. Avoid the assessment trap. At this point, you're not asking a whole bunch of questions about history and other outside questions. It's the 3 questions that show up on that flow chart that we're going to be focused in on, and then building the support, checking for confidence, and then putting a follow-up plan in place. All right, so if done correctly, you guys should not look like this, and the patients, families that you work with shouldn't be looking like this. I know if you tell me what to do, I'm the guy in the middle. I'm like this. Like I don't want to hear. That's just most of us do not like being told what to do, and so just keep that in mind. And sharing with you that brief action planning is motivational interviewing, and it's for a core group of folks. If you think about this may be one way to get to the framework of when people come into your hospitals and your clinics. You know, you got your usual care folks just need a little bit of support, send them on their way, and they're good. And so we're trying to find those folks that are right outside that usual care group that are poor clinical control, high self-confidence, or low self-confidence, good clinical control. And those are the folks that action planning is a good fit for. People you have a relationship with, you know them, you know, with a little additional support, we can get them back into the green. But this is the piece right here that's really important. You got to support people differently. Sometimes people show up and they're in red. These are the people that have a lot going on, they're struggling, and we're going to support them using MI, but we're not going to put a goal in place. We're not going to do action planning. What we're going to do is support them using affirmations. We're going to use, you know, over time, support them by sharing what life could be like if they made the changes. Positive thinking, forward movement, all of that's wonderful. And that just takes time with a lot of folks who are showing up and they look like this, you know, this chart, you know, these are the folks that are in red. So as I said, BAP is not for everybody. There's some folks that you're just going to support on an ongoing basis with all the support you can give them, but you're not going to necessarily put a a brief action plan or do any action planning with them. We're looking for those folks that are right outside the usual care group that end up in these 2 yellow categories. Those are the best fit for the action planning folks. I wanted to share another tool. This is a tool I'll make sure we send out afterwards. And let me just see, I might be able to get this to show. I'm gonna try to click out of that and just share. There we go. It's a brain tool. It's called the brain tool because this is a shared decision-making tool. And you guys may find this very useful for COVID or for helping people in the hospital, families, caregivers make difficult decisions. It has to be an informed decision. So the acronym is BRAIN: benefits, risk, alternatives, intuition, and next steps. And so you really would fill this out with the patient. If they can fill it out, you're just talking it through with them. You're walking through the conversation with them. It helps them make an informed decision. So what is the decision I need to make? How much time do I need to make this decision? Who's involved in making this decision? And these could be bullet points, just really things that are important to consider in making an informed decision, making a good decision. What are my values that affect this decision? And so you just, on each side, you begin to ask these questions. How might this benefit me if I make this decision? How might this benefit the people close to me? Then what are the risks? How might this pose a risk to me? How might this pose a risk to the people close to me? What are my alternatives for the short and long term? What are the choices? Do I do nothing? Or what other ideas do I have? What are my alternatives? And then what do I feel and think about these options? And then the next steps. I need to talk to people close to me. I need to think my decision through. I want more information. I want to wait. I want to talk to a professional. I'd like to something else that may have come up as you're in this space talking this through with them. But if you think about any decisions you ever made, these are the core components of that decision. And being able to have a structured way to do this, this is a form. It's something you can do on the screen on your computer. You can have it printed out, but it's a way of being with someone and helping to give them, what they should think about, what they can think about to make an informed decision. So this is the brain tool. Remember, to make an informed decision, it helps to use your brain. Just want to share that. Okay. Becky?
Yes, thank you.
That was the end of my presentation. I don't know if you want to spend some time doing a quick session of question and answers. This was supposed to be an engaging interaction. So hopefully folks are there and we have some questions.
I would just like to say, though, that the trainings that you have provided for people, feedback that we've received has been that it really helps the providers drill down to what matters for the patient, and that the individuals that utilize this style have really learned to listen to the patients more intently and really get a better handle on their social determinants of health, on their concerns, and overall patient outcomes. They just feel like they have a bigger impact on them, and follow-up is better. So definitely has proven to be a best practice. So questions for Brent? Please feel free to chat in any questions. If you're interested in any trainings, reach out to Brent or I, and we'll be glad to assist with that.
And Becky, I'll just share those trainings. They're 4-hour trainings. And I thought, when we went virtual, I'm thinking that's going to be a lot to ask. Becky and I've done a lot together, and I do many of them across the state. The 4 hours flies. And it's because it is set up in a way that it's a combination of videos, it's a combination of didactic training. It's really talking through how they can use this in their respective settings. And then we do practice and feedback. And literally the 4 hours, I'm just shocked as a trainer, the 4 hours, and for the folks participating, it flies, and it does every time we do it. So, and the evaluations are really, really good. So your teams, the teams going through the trainings tell us they're getting a lot out of spending time and really getting a chance to learn some new skills. And then it's engaging. So, you know, what we're hearing, there's a reward on both sides. There's a shift in ownership. It's people have to make the change. And so the more we can get them to come up with their own plan and support them, the more the pressure comes off of the health system team. So there's a relief on this side. And then there's, you know, this ownership. This is what I got to do. I said I'm going to do this. So there's kind of a win-win. When we're hearing that, when they practice it, they start to feel it. And then when they actually do it with the patients, they come back and tell us this has made you know, it's really helped change it's changed the conversation, and it shifts the ownership of, you know, they have to do it. We can't make them do it. And the way that we do it, the trainings help support those folks in making those changes.
We do have one question. How long does brief action planning usually take with a patient?
2 to 5 minutes. Yeah, and it may take a little longer if you're newer at delivering it. Just as you're practicing, it's like getting up on a bike. You don't necessarily ride it the best you can the first time you get up. So just through practicing, and even if a patient needs a lot of support and it takes time, it's like 8 to 10 minutes when you're first getting started. And ideally, what happens as you get more proficient and efficient at using it, it's 2 to 5 minutes, and you can have a self-management support plan in place in that amount of time.
Great. That is the last question that I've had come to me. Okay. Well, thank you so much, Brent. We really appreciate the information and the tools to be able to use. So everyone, just keep Brent in mind. He does a great job facilitating the sessions, and the 4 hours sounds like a long time, but goes very quickly. So, okay. Thank you, Brent.
Thank you, guys.
And Don, I'll turn it over to you.
Thank you, Becky. I have the easiest job today, which is to wrap everything up and thank everybody for participating. There's so many people that have been part of this. Our speakers today, I want to give a big thanks to, but also our hospital participants for taking the time today to come and learn and to share with each other. I want to congratulate all of the award winners. I do want to say it's very important. We do have a $25 gift card. It's a raffle for those that do the satisfaction survey that you'll be getting. So please do that, and you'll be getting that. If you complete the survey, you have an entry into that raffle. The hospitals that are on here, you know, I not only thank you for attending, but for the hard work you've done throughout this year through COVID and this most recent surge. We know how hard it's been on you, and how important your time is, and so that's why we're so grateful that you're here with us today. Our next meeting is going to be in the spring. We don't have the date yet, but are looking towards the end of April. And like always, we're planning for a face-to-face, but investigating a virtual option, even if we are face-to-face, so those that are unable to travel still will be able to join us virtually. And very hopeful that COVID will be at a level where we will be able to meet face-to-face. There's so much more networking and information exchange we can do when we're all in a room together. Again, the slides, the presenters, the slides and the presentations are going to be shared. And we'll share confirmation from our presenters in our email that are partners on this critical access hospital convening meeting. If we don't have the answer for you, or able to provide the services, we're going to connect you with the right service. So any one of us, just reach out and we'll get you in contact. We meet regularly together so we can get you to the right place. Again, I think that's all I have, Becky. I want to thank everybody for being with us. We're going to get you out a few minutes early today, but there's been a lot of great information shared. And some good questions and good resources shared today. So I'm very happy we're be able to provide that, and looking forward to our next meeting.
Thank you. Goodbye, everyone.
Thank you, Becky.